So good morning. Today we're here with Amanda Dozier, and she is a critical care nurse.
Yes.
So can you tell us a little bit about what it is, critical care, and what the population of patients you see?
Well, the critical care is an area where patients are that need a lot of extra care. The nursing ratios are usually one nurse to two patients at most. You rarely see three patients to one nurse, and that's because the patients are that acute and that needy. Our patient population in the area that I work is we have 14 beds in our ICU. We have anything from cardiac patients who've had really bad heart attacks all the way up to patients who have really bad respiratory problems, people who have sepsis. You get a little bit of everything. Some folks that have tried to harm themselves, and so they've overdosed on medication, so we have to protect their airway, or people just need a little extra monitoring.
What's the age group that you usually see? Is it mostly adult, or do you get some children?
We don't see anything below the age of 18.
Okay.
I have worked in ICUs in the past that did take patients down to age 15, but we don't do that here. We have 18 and up, but I generally see anywhere from, I'm seeing a lot of 50-year-olds, and then all the way up to, 102-year-olds.
Oh dear.
So yeah, you get a couple of those too.
Okay, so they don't separate the unit out by cardiac on one side and the rest. No,
No, it's all mixed.
You as the nurse could see a variety of
Anything,
patients.
which is nice because I keep all my skills that way.
So what's the educational level required when you enter into such a unit to work?
Most critical cares want a bachelor's prepared nurse, and because you do have that background, that theoretical piece as well. And then they want you to have an additional, usually somewhere between 18 weeks to 6 months or more of good critical care additional teaching. You get a little basis in your bachelor's degree, but then you get additional. If you're in a good unit, they'll give you additional training so that you feel comfortable and competent when you're on your own.
So with your bachelor's, they'll hire you into the unit, and you get the coursework right there on the unit to further your education in that area?
There are several programs out there on the market. One of them is ECHO, ECCO, and you can look that up. Another one is just unit-based, where it's very personalized by the unit educator, and they do one-on-one. You'll be hooked up with a preceptor who is a seasoned ICU nurse who knows the unit and knows how to be an ICU nurse and knows the patient population. And usually it's about 18 weeks, give or take about 8 weeks, depending on the unit you work on. And they just help you kind of ease in. And then usually they'll do it on a case-by-case basis. Are you ready? Do you need a couple more weeks of orientation? Are you missing a certain thing? Did you just not get any code blues? And you really need to be able to run one of those. Did you not get to see a balloon pump? Did you not get to see something like that? So those are the things that you want to look at if you are looking at getting hired into a critical care. You want to see what kind of orientation they have, because you do not want to get left on your own high and dry and not have proper training.
That's a good point to look into that. So the role of the bachelor prepared nurse on the unit, are they doing total care, or do you have assistants that you delegate to?
Well, I've worked in different ICUs in the past. I've actually worked in 3 different ICUs in 3 different states, and it depends. There's the one that I worked at in South Dakota. We always had a CAP or a PCT or a CNA kind of a based person. But a lot of times in the ICU, it's the nurse who does everything, and you're very much the delegator to that PCT or that CNA, because you don't want them to harm them. And there are lines and wires coming out all over the place, and if one of those gets pulled out, that could be life or death for your patient. And they don't have the training to know what those lines mean necessarily. They just know they're important.
And a PCT is
patient care technician. That was Arizona's, and they can do just a little bit more than a CNA can. They can do lab draws, and some places they allow that. They can do lab draws. They can put in Foley catheters. Most of us in the ICU are a little bit more possessive of our patients, and we don't let anybody do anything without us there. It's just kind of the nature of the beast, because
you're monitoring for infection and you're making sure
I don't ever let a person
respond during the procedure.
Nobody else ever bathes my patients for me, because that's my opportunity to do an awesome skin exam. That's my opportunity to listen to their back when I can't get behind them because they're so hemodynamically unstable. So I'm always in the room if somebody else is in the room with my patient. And you'll find that a lot of the ICU nurses are that way, because they're just that sick. Yeah.
Good to know. How about certifications? Does the nurse need a national certification, or is that something that the hospitals want when you get into critical care?
Well, a hospital would love to have a national certification. I mean, basic certifications, you need to have your ACLS, which is Advanced Cardiovascular Life Support. You need to have that and your basic life support. That's absolutely a must-have. Many places will train you in ACLS before you're ever on the floor, but it would be awesome to have it before you came in. A lot of them want you to have your stroke certification, your NIHSS, so your National Institutes of Health stroke scale certification, because we do see a lot of strokes, and that's a big push nationally right now to have stroke centers of excellence. The place that I work at is a stroke center of excellence, and so that's important.
Where do you get that certification?
You can get that online. You can get it through the American Heart Association or American Stroke Association. They do that. I believe it's a $10 fee. There's also another one. I think it's at stroke.org. You can get it for free. And it's a bunch of videos where you grade the patient's symptoms of stroke, and you give them a score at the end, and they're basically making sure you know how to do the grading system.
And then, so the education for that, is that provided in this
In many cases,
certification
yes.
class?
In many cases, yeah, it
Okay.
is. You mean for the NIH specifically, or for the
If
critical care
if they're
class?
going on, either one, if they're going on for the critical care,
Mhm.
so they get a hold of ECHO.
Mhm.
If they need the stroke one, they
Mhm.
get a hold of the stroke.org.
Yep.
Is there information there where they can get the education
Yeah.
to be able to pass these
Oh,
tests?
absolutely, it's right there for you. And the level one, they give you the whole piece and the background on it and what you need to do, and then they give you examples on how that patient would be graded. And then as you do it, you need to recertify every year to 2 years.
Okay.
And as you
Stay
recertify,
current.
yes, exactly. And so as you do, and make sure you know what you're doing, because you may not have seen enough stroke patients over the last year to 2 years to remember what you're doing. And then, oh my goodness, I have a stroke patient coming in, and oh, I can't remember how to give them an NIH stroke scale score. And that's kind of important.
So it would behoove the nurse
Mhm.
that wants to go into critical care to
Get
study this, get these certifications, get them on the resume.
It would be awesome. They're going to be way more marketable if you can have those certifications to begin with. And I was actually teaching an ADN program, and I encouraged my students to get that NIH stroke scale certification because it would put them head and shoulders above the rest when they tried to get their first job. So it is a huge piece. And I did a lot of review of resumes in my career when I was working as a nurse educator, and we had a panel interview, and people who had those extra certifications just stood out.
So, talking of certifications
Mhm.
and the education that you need, what is your background?
So I did a bachelor's degree program, 4-year, graduated, and then I went into rehab and decided that that really wasn't what I wanted to do. I had been a CNA in rehab, it was comfortable. And so I went into a critical care med-surg float pool because I had no idea what I wanted to do. And fell in love with critical care there. And went through critical care and decided I was going to move to Tucson. That was in South Dakota originally. Moved to Tucson, Arizona, and they hired me direct into a med-surg ICU. And got fantastic experience there. They gave me additional training so that I was able to do balloon pumps. I was able to do CRRT, which is continuous renal replacement therapy. I was able to do, just code blues and complex situations, rapid response type of things. I was also able to do rapid infusers for patients who had a trauma of some kind where you need to get blood and fluids into them quickly. Those kinds of pieces of equipment that you don't see on a regular basis. So I had a lot of extra experience there. Then they decided to open a neuro unit, and I hated neuro. Was never going to do neuro, but they said, could you please help us out over here? We just want to get this unit started. So I went over to neuro ICU and was a charge nurse there and got some awesome training in specific neuro things. When you've got the people with what look like antennas coming out of their head, they're actually pressure monitors in your brain. I was able to do those. And then I moved into the educator role when I got my master's degree. I got my master's degree in nursing education, moved into the unit educator role, was able to train people through ECHO. I was an ACLS instructor, did all of those pieces. And then when I decided to move here to Boise, I decided I wanted to go back to the bedside. I missed the bedside. I didn't get enough hands-on, went to the bedside, loved it, and now I do rapid response. I do code blue team, and then I work at the bedside as well. I got my critical care nursing certification, so I'm a CCRN. That's through AACN, American Association of Critical Care Nurses. And then I also went through, about 5 to 7 years ago, I got my neuro certification. So I'm a certified neuroscience registered nurse as well. So that's an CNRN. and that's through the American Association of Neuroscience Nurses. And a lot of the units really value having those certifications, especially if it's a magnet hospital. And I don't know if they know a magnet hospital. So a magnet hospital is one that is very much about nurses and nursing autonomy. And so when you're looking for a new job, if you can get into a magnet hospital, the nurses are treated well. There's a lot of nurse-run committees in the unit. There's a lot of nursing research that goes on. Evidence-based practice is at the forefront, and they seem to be way more pro-nurse. And that's nice when you don't have you don't feel like a peon. I hate to use, for lack of a better term, you don't feel like a peon. You actually feel valued. Mm-hmm. And they really value your education and furthering education. And so they would have paid for some of my tuition with my master's degree if I had decided to do that then. They value higher level education in nurses. So my master's degree spoke highly, and they really wanted to hire me, and they treated me like gold because I chose to pursue education. And you don't see that in every hospital. So
no, that's something to look for.
It is. It's a huge benefit. And a lot of the critical cares you're going to find they really push for those extra certifications and for higher education, because it's going to take in the future, I think it's going to take a higher level education nurse, because we are having so many new pieces of technology coming out. The patients are getting sicker and sicker, and they're living longer. And so you're going to see higher levels of critical thinking, more need for education.
Well, you've mentioned quite a bit of the technology mm-hmm. that they have there. How does that affect your ability to have a rapport with your patient? They're very, very sick. Mm-hmm. You've got all this technology mm-hmm. around. I just can't imagine seeing family members in there and having a nurse-patient, right. nurse-family experience. What is that like?
Well, a lot of times you've got patients, we're learning that you don't want to have your patient just dead to the world on sedation when they're on a ventilator anymore. We're learning that that's not beneficial. We used to think, we want to put them out, make sure that they aren't aware of what's going on, because this is going to be a traumatic experience for them. Well, we're finding that if they're allowed to be aware of the environment and what's going on, and just give them enough comforting medication to keep them calm, then they're actually going to recover faster. So we're having these patients on ventilators, and you're doing a lot of therapeutic communication when that anxiety starts to get the best of them, and it takes a little while for that medication to kick in. So you start talking to them using your therapeutic communication techniques that you've used in the past, and you have to overcome some challenges. They can't speak back to you. So some of them can write, but some mm-hmm. of them are restrained because they want to rip that tube out of their mouth. And so you may have to go by, can you blink for me? Blink once for yes, two for no. Can you mouth words? And you get really good at learning how to mouth read around a tube.
Oh my.
And then you've got your families in there. And remember, everybody in the room is in crisis mode. So you can,
I imagine it's very frightening for a family member.
It's incredibly frightening. And so remember that the patient is not just the person in the bed. The patient is everybody in the room who loves that person. And so a lot of times you are using your therapeutic communication with them as well, in reassuring them. The more knowledge they have, the more comfortable they feel, and the more the helplessness goes away. They just feel completely helpless, and they're afraid to touch them because they've got all these lines and tubes coming out of their face mm-hmm. and their hands, and they're afraid if I touch their toe, I'm gonna screw something up. So you have to reassure them. You can touch them here. Please hold their hand. Talk to them, or they really need to not be stimulated right now. Let's kind of just hold their hand and not talk. Let's just sit here, and I'll turn the TV on for you, and we'll keep it on low so we can keep that stimulation to a minimum. And you really need to have that open communication back and forth, and make sure that they're comfortable asking questions. You have to have that patience and that willingness to answer those questions, because they have thousands of questions.
Oh, I can imagine.
And so you really do. You form a great rapport with not only the patient, who may not remember anything that you've told them, but in the moment when you were calming them down, they know you. They may not remember in 5 minutes that you were their nurse because of the medications we have them on, but in that moment, you're making a difference. And with the families, they'll remember you for a lifetime, even if you've only spent one night with them, because that one night was so traumatic. And so if you can make it a little bit better, that's great. And what these folks have seen, the family members, in a lot of cases, is what they've seen on TV shows, ER, Grey's Anatomy, those Life in the ER shows that are supposed to be real, and they're not. So you see these kinds of scenarios that they have in their head already, and they come into an ICU expecting it to be that way, and it's not.
So you're quite the educator.
Yeah, nurses are educators by nature. That's our job. And the more you're willing to talk and communicate and teach, the better your experience as an ICU nurse is going to be too.
And for the family and the patient.
Especially.
So where do these patients on your unit transition to?
Most of them are going to move to, we're moving toward a step down unit, but currently we just have a telemetry. So in a lot of cases, you've got these patients who are on one drip, one pressor. When I say a pressor, I mean a medication that's going to keep your blood pressure up.
Okay.
You've got them on maybe one vasoactive medication. You might have them on cardizem, which is an antiarrhythmic drug. You might have them on just one medication that we can't quite get them off of yet. We try and wean it, but it's just not working. Those patients right now can't go to a telemetry floor if you're titrating down that medication. A step-down unit, they'd be able to as long as they're lower acuity than what would be in the critical care. So once they're off all those medications, they go to telemetry where they're monitored with a portable telemetry monitor on their chest, and then they can ambulate in the units and start to get their therapies there and feeling a little bit better. They're transitioning from IV medications to PO medications in a lot of cases, and they may discharge directly from telemetry, but usually ICU, we don't very often discharge direct from ICU. It's pretty
No,
rare.
I think that would be terrifying if I was the family member.
Right. The only time I've seen that is when you have a patient who tried to harm themselves and with, overdosing on medications or something
And you
along those
bring them
lines.
completely out.
And you bring them so that they're stable medically, and then we transition direct from the ICU to an inpatient psych unit. That would be the only time I can really see discharging.
So these patients and the families have been there. It's very traumatic. There's a lot going on. They transition to these other units and then home. How is all this coordinated so that the family member
Is
feels comfortable
Right.
taking this person home?
Right. Well, in a lot of places, you've got a case manager or a social worker, and the case manager or social worker, they're in there trying to organize all of the things. They might need home health, they might need to go to a subacute unit place for a while. There's like Kindred's, and here we have Vibra, and
So these are skilled nursing facilities where
Sort
they
of.
can transition down into a
Abs-
special unit there.
right. And some of them actually do ventilator weaning.
Oh,
Where when you've got those patients who you've got them off everything else, they're stable, they just can't quite stay off the ventilator yet. They're breathing and they just poop out. They go to a place that is specialized in vent weaning, and so Vibra would be our place here, or Kindred's, and some of the other areas. Those are very common. But then otherwise we have skilled nursing facilities. We call those SNFs, or nursing homes, which are a little lower level, and some of them need to go to an assisted living because they just can't manage their medications. Lots of the admissions that we get are because, an elderly patient can't keep all of their 20,000 medications. That's an exaggeration, but a lot of them are experiencing polypharmacy to a point of dangerous levels.
absolutely.
And they're making their own med errors at home, and that lands them in the ICU because their heart rate dropped to 30 because they overdid their beta blocker, or their heart rate is crazy high because they didn't take it because they couldn't check their pulse, and so they were afraid to take it, and so they went back into atrial fibrillation and maybe through a clot. So those are the patients, because of med errors, we're seeing them get admitted, and so they may need to go to an assisted living where somebody can help manage their medications. So you see a lot of that. And a lot of that stuff, the management of that actually comes from the nurse. The nurse is the one who does a lot of the coordination of care and contacts the different people who need to play a part in this. And the nurse is the coordinator of care, especially in the ICU.
You're there, you're assessing the needs and you're assessing the family's needs. So you're a vital part in
Absolutely.
this discharge plan.
Absolutely. And the nurse, too, is the one who tells the doctor, this patient's going to need this. This patient's going to need this. And the doctor's job in that case is a lot of times to say, okay, I'll order it.
So good collaboration with the
Yes.
doctors, good communication with
Yes.
everybody.
Lots of communication. I can't stress the importance of being a good communicator in the ICU. If you don't, it'll kill your patient. I mean, these patients' lives are literally in your hands, and it's scary. And they're sick, and they could go bad within minutes. You had a patient you were talking to, and the next minute they go into VFib, and you're doing compressions and shocking. I've had that happen on more than one occasion. It's scary every time, but these people are sick, and you have to be on your toes and know that next moment they could crash on you.
So I've got all this technology going on and critical issues with patients and families and assessing and discharge. Why would I want to go and work in a critical care unit?
Well, if you are an adrenaline junkie, It's a great place to be because, like I said, you never know what's going to come next. Those people who
That
like
could be exciting.
absolutely, there's some excitement there. The other piece is that you actually get to see in real time these folks get better. I watch their blood pressure go down. I titrate my pressor up a little bit. Their blood pressure's fine. I mean, it's instantaneous. You know, they're freaking out on their ventilator. They're trying to rip that tube out. I go up a little bit on their medication and calm them down, and now they're able to communicate with me and not freak out and want that tube out. And you know, it's instant gratification, I guess, is a really good.
You can really see making a difference in people's lives.
You can see making a difference, and that makes a difference to you and your satisfaction with your job. So, it's ridiculously rewarding, and a lot of times it's very taxing emotionally because you do lose patients, and you do form a bond with their families. You do form a bond with the patient themselves, and then you lose them. So,
is there support available to the nurses then?
in most places, that's something else to ask when you're looking at going into an ICU. You want to ask, you know, what kind of support do you do? Do you do debriefings when you have a bad code? Do you do any kind of support? We use chaplain care a lot, and they are not just for patients, they're for nurses as well. And then your boss is going to be a key player there. They're the ones who kind of come by and give you that little hug and say, are you okay? Do you need a moment? And your coworkers are great too. They know when you've had a bad day, and they'll say, why don't you just step off for 15 minutes and just go gather yourself and then come back. And so it's all about supporting each other, and you'll find that if you don't have a good teamwork and a team rapport, you're not going to enjoy your job. So,
Well, great. Well, thank you very much for all this information. I'm sure some of our students are anxious to get into the critical care units.
hope they do.
All right. Nice meeting you.
Nice meeting you.